Hi guys, my name is Dr. Zahid. I would like to discuss a case scenario. There was a case which I did in my senior residency. There was a female of around 40 years old and she had a history of typhoid, and because of that she had typhoid ulcers. Those ulcers were ruptured and that led to peritonitis. Now majorly all the reports were fair enough, they were good enough in the range, but the only problem was that her TLC count was around 40,000, which told us or gave us the information that the patient has severe sepsis. Now when this patient, this 40-year-old female, came to our emergency, I had to do the primary anesthetic evaluation or the pre-anesthetic evaluation. Now because of so much sepsis, that is septicemia, she had a very altered sensorium, right? So the pre-anesthetic evaluation which I was doing was not very substantial. So I had to trust on the reports. I auscultated her respiratory system. I did an auscultation on the CVS, which was more or less, it was towards the normal range. Now I had to rate that patient in the ASA classification. But before moving on to the classification, there is one more important thing, that was the MPC classification. Now that patient was so intoxicated that she was not able to properly answer my questions. I asked her to open her mouth, but she didn't open her mouth at all. Now when I was visualizing that patient, I saw that she could barely open her mouth. Now we took that patient inside the OT, but at that moment I decided that I'll try to see whether the patient can ventilate or not after giving the muscle relaxants. So what I did, I gave a small amount of induction agent, and that was propofol. Why did I do that? Because I know that the recovery from propofol is fast enough. When I gave a small amount of propofol, the patient went under sedation, right? I didn't give the anesthetic dose. I just gave the sedative dose. Now what happened? I was able to ventilate that patient. There are two scenarios in which we have to see that. The first scenario is cannot ventilate, cannot intubate. Now that is a very life-threatening condition. But the other scenario is that can ventilate, cannot intubate. So that patient fell under the criteria of can ventilate, question mark whether we can intubate her or not. Now I decided that I will be going to paralyze the patient. That muscle relaxation which I am going to give is going to be a depolarizing muscle relaxant. Now why I decided upon that? Because as we know that we only have one depolarizing muscle relaxant, and that is succinylcholine, right? We have succinylcholine. And why do we use succinylcholine? Because it has a faster onset of action and a shorter duration. Now when I gave succinylcholine and went on to open the mouth of the patient, I was not able to open the mouth of the patient. Now in that scenario, what we did, that we kept on ventilating the patient. We had a discussion between other anesthetists and we finally landed up tracheostomizing the patient. The ENT team was called and we intubated the patient by having a tracheostomy. Now the important point was why this thing happened with this patient. Now after the patient got operated, the relatives came, her son came, and I asked her about the detailed history of the patient. And that patient was a chronic tobacco chewer. And because of that, there was ankylosis or joint stiffness of the TM joint. And that is why the patient was not able to open her mouth properly. So guys, whenever you see or tackle with any subject, you have to have a detailed history of the patient so that you can have a proper management and you know beforehand only that what are the steps you are going to take for a better outcome of the patient. Now all these things are just for your general information. Just keep watching the videos from PrepLadder and you will have a better future. Thank you guys.